It's a difficult situation in the sense that there's one big randomized controlled trial in the US that was positive. So there was a clear-cut role in screening for non-small cell lung cancer. But the only big issue is that in the US they then referred about 24% or so of people for further investigation. And that's something we would not do in Europe. That's way too much. It's not a fault or something. It's just that in the healthcare system in Europe, the Netherlands, anywhere in Europe, I think, we want to go for lower referral rates. Indeed, there are a couple of European trials running now. They are far ahead also, so we think we are almost getting the results, let's say, within years. The big difference is that we look at nodules, we look at the volume of the nodules. So in the US trial, they just looked like the maximum diameters. In the European trials, we look at the volume of the nodules, and we can then say, for instance, for some nodules that are sort of intermediate, we say, please come back in 3 months' time or so, within 3 months' time, and we can make another CT scan and see whether that volume has changed. And then we basically get a better estimate. So the big difference is looking at the volume of the nodules and the volume doubling time of these nodules. And that is really novel, and that is really, we think, helpful in reducing that amount of referrals.